So good afternoon. I'm Jagat Narula. I'm the president-elect for the World Heart Federation, following Dr. Daniel Pinheiro, our current president. So distinguished delegates, our guests, ladies and gentlemen, it is my immense pleasure to welcome you to our side event, vadis, assessing the journeys towards Sustainable Development Goal 3.4 and steps to reduce premature mortality from cardiovascular diseases. I'm honored to open our debates as we gather to address one of the most pressing public health challenges of our time, non-communicable diseases, and more specifically, the cardiovascular diseases. The UN Sustainable Development Agenda has set forth an ambitious target under SDG 3.4 to reduce premature mortalities from NCDs by a third by 2030. Cardiovascular disease represents the heaviest burden within the non-communicable diseases, disproportionately affecting low and middle income countries and exacerbating social as well as economic inequalities. The disparities in cardiovascular health are significant and access to treatments and care remain inequitable. Nowadays, the digital divide further compounds these inequalities, affecting self-monitoring, access to treatments, and overall cardiovascular outcomes. This event will set the stage by reflecting on why the words "number one killer" receives disproportionately little attention as a priority in terms of resources and policy. The conversation will then progress to what a bold vision for cardiovascular care looks like, in particular, the need for an approach that recognizes the multimorbidities of cardiovascular disease, including renal and metabolic conditions. The discussion will highlight the many benefits to the society that a refreshed approach would have and how this translates into national plans. I would like to extend my gratitude to our sponsor, Boehringer Ingelheim, for their generous support in making our event possible. Together, through collaborations and shared commitments, we can further reduce the global burden of cardiovascular morbidity and mortality. Meaningful progress towards UN Sustainable Development Goal 3.4 cannot be achieved without meaningful investments in cardiovascular health. So thank you very much. And now I introduce Jackie Thornton. She does not need any introduction. She's a very well-acclaimed journalist, and you must have known her from The Lancet and British Medical Journal. Jackie, all yours.
Thanks so much, Jagat, for that very, very kind introduction. And yes, I'm delighted to be here to moderate this important event. And thank you again to the World Heart Federation for inviting me, and to Boehringer Ingelheim for supporting the event. As Jagat says, this is a really, really important issue. We think, but we don't know exactly how many countries are on target to reach the SDG 3.4. Maybe 14, that's been a number mentioned, maybe fewer. There are some thoughts that people have forgotten or are not saying a number anymore because it's going down. So we want to know, why is this happening? What is hindering progress? Why is it not a priority for governments? Why does cardiovascular disease not receive the attention it deserves in terms of policy formulation and implementation and resources? What are the barriers to pushing through this new vision that Dr. Narula mentioned? So we're going to attempt to address those issues today. We're going to have a panel discussion later on, and there will be a time for questions and answers from the audience. But actually, I want to set the scene here. I want to welcome Dr. Tom Frieden to the floor. Now, as you know, Dr. Frieden is President and Chief Executive Officer of Resolve to Save Lives, and former Director of the US CDC. He's going to talk about Resolve's mission to end preventable death from cardiovascular disease by partnering with government and civil society to implement scalable and proven strategies. So, Dr. Frieden, thank you very much for coming to talk to us today, and you have the floor.
Thank you very much. So, we're here again, and we're in the same situation. There's been very little progress addressing SDG 3.4.1, to be precise. Cardiovascular disease is the world's leading cause of death. I'll start with a story. You know, the name of this session is vadis, and Judge Oliver Wendell Holmes, very famous Supreme Court justice in the United States, was boarded a train, and the conductor came to collect tickets, and he looked in his pockets and pockets. He couldn't find his ticket. The conductor says, "Don't worry, Judge Holmes, we all know you." He said, "The question is not, who am I? The question is, where am I going?" Now, where are we with hypertension, the world's leading cause of death, more than 10 million deaths a year, 1.3 billion people with elevated blood pressure, 4 in 5 living in low and middle income countries, the single most important cause of early death worldwide. 4 in 10 deaths are among people under age 70. And for every death, there are at least 2 non-fatal cardiac or cerebral events, leaving you with disability, lost productivity. I was traveling in China a few months ago and went to a hospital, local hospital. There was a man who had had a massive stroke. He had been a tofu maker. He was 53 years old, right? He has no more economic productivity for his life, in all likelihood, in that context. His family has to spend all of their time taking care of him, all from uncontrolled hypertension. And it would have cost less than $5 a year, efficiently procured, to give medications that could have prevented that disability, that stroke. High blood pressure treatment can save more lives than any other adult primary health care intervention. And just if we reach 50% global control by 2050, this could prevent 76 million deaths, 120 million strokes, and 79 million heart attacks. But what we're seeing is too many people undiagnosed. Many are not in effective care. Medications can cost as little as a penny a day, and yet they're not available. And when we think about non-adherence, I know this topic comes up, with the same patient population, good health systems go from 10% control to 80% control. So the adherence didn't change. We can't blame the patients, and I'll come back to that in a minute. So where should we be going? Hypertension treatment has been standard of care for half a century in high-income countries. It needs to be standard of care for every person in the world with high blood pressure. The World Health Organization Hearts package is evidence-based. It's been proven to work. It's a strategic approach to strengthening cardiovascular health management within primary health care. And really, if you think about what it is, it's all of the essential aspects of primary health care. The first component is evidence-based protocols. The second is supply chain management. The third is team-based care. The fourth is patient-friendly services, patient-centered services. And the fifth is an information system that empowers healthcare workers, empowers supervisors to improve the care given to patients. Currently, more than 20 million patients are in Hearts-style treatments around the world. We've seen from Bangladesh to Ethiopia to India to Sri Lanka, government-led programs have doubled control rates. And interestingly, we've seen a coalescence on the WHO indicators. If you look up Hearts 360, you can see an example of a dashboard being used in many countries to really address the single most important question: how many patients did you get under control last month? And you can then say, since as an epidemiologist we lose sleep over denominators, what's the proportion of total people in need? We have to somehow give a number that policymakers can understand. So 400,000 people given treatment last month, best treatment in the world to protect their hearts and their brains from a stroke, a heart attack. And we have to figure out ways to speak more effectively about what's happening. I'll come back a little bit to that, but I want to talk about sodium reduction. Thanks, some of you were at the morning event also. Sodium reduction and potassium increase is the most proven scalable intervention to prevent hypertension or reduce the need for treatment. Excess sodium intake is the leading dietary risk factor for premature disability and death. At least 1.9 million deaths every year. Almost everybody consumes too much sodium. It increases the risk for heart attack, stroke, and kidney disease. Salt reduction is a WHO best buy. In fact, it's one of the few things that's not only cost-effective, but can be cost-saving. Now, evidence-based policy interventions work, and countries can build on global best practices, but just as was said with 3.4, there is a way forward to achieve 3.4. It involves big progress against tobacco, trans fat elimination, treatment and prevention of hypertension, treatment of cancer. It's doable. It's within reach, but it's not happening. In terms of sodium, 10 years ago or 11 years ago, the world committed to a 30% reduction. Not a single country is on track to achieve that reduction. So we're really looking for countries that are going to go all in and make a difference. We heard from Colombia this morning, and they're really doing a lot. They have front-of-pack warnings, they have taxation, they have marketing bans. So we're eager to see what happens in Colombia with their efforts. But we have to look at the sources of sodium, including out-of-home food. No one's really figured it out. How to deal with restaurant and street food. We have to deal with packaged food. Packaged food, we have a pretty good way forward with mandatory limits, front-of-pack warnings, limitations on sale and marketing. So you can't market anything that's unhealthy. You can't sell it on public land or public property. You can't pay for it with anything with public dollars. We have a way forward. Mandatory limits, those stop signs or other culturally appropriate images on the front of packs, and scaling up the use of potassium-enriched low-sodium salts. Potassium-enriched low-sodium salts are the closest thing we have to a vaccine to prevent hypertension. Now, just as with vaccines, don't take more than is recommended. We really need to get the point across, eat less salt, and the salt you eat should be potassium-enriched low-sodium. Low-sodium salt looks, tastes like regular salt. It is more expensive, and so fiscal measures that might cross-subsidize low-sodium salt by taxing salty items is one way to move forward. I think that as we think about universal health coverage and health care, we need to think of hypertension control as the leading indicator for adults, in addition to vaccines for kids and effective reproductive, maternal, and care for women. We have to ensure that each population gets the most effective services to get the maximum health benefits. Every day we wait, 30,000 people die from hypertension-related causes. In the few minutes I've been speaking, 200 people have died. And 400 people have been like that tofu maker I met in China, have had a non-fatal stroke or a heart attack. We need more focus. We need to maybe downshift the things that are not having massive impact and focus on control rates, focus on strengthening systems, focus on advocacy. We know what to do. We can get it done. The Heart's technical package works. Sodium reduction strategies work. And we have to ask ourselves, what's not succeeding? Why are we not making the progress we need to make? And for that, I think we need a combination of commitments from governments, pressure from civil society, rigorous monitoring, like the WHO report that came out last year that tells us exactly where we are, so that together we can go to a much healthier place where heart attack and stroke are as remote as the diseases that we have conquered over the past half century. Thank you very much.
Thanks very much, Tom. If I may, I just wanted to press you on, what are some of the barriers that are actually stopping, the structural barriers that are stopping progress happening. And I wondered whether you wanted to reflect on the million hearts in the US, potentially as use an example.
Thank you. Thank you for reminding me of a failure. We spent enormous effort to try to get Million Hearts through in the US. We had the Secretary of Health and Human Services, which is the equivalent of minister in other countries, every week tracking it. We had every agency working on it. We had every non-governmental agency pushing, and we failed. And the reason we failed is that we didn't look at the money. We didn't look at the financial incentives of the system, and we didn't look at the politics that was driving the money. At Resolve to Save Lives, we have a triad we talk of, which is TOP: technical, operational, and political. You need to get all of those things in place to succeed. With hypertension and control, on the technical side, we're really getting there. We understand now the basics of regimens. You know, I'm basically a tuberculosis doctor. I was shocked. You know, we don't have a regimen for hypertension. Well, now we know. Virtually everyone should start with amlodipine, right? You can vary some after that. But, you know, there's FDCs, there's other things, but we have a regimen. We have equipment, validated blood pressure monitors. We have WHO policies on which blood pressure monitors to use. So technically, it's pretty much available. Operationally, it's about management. But politically, it's about, you know, if you talk to the political scientists, they say, you public health people, you're so naive. You say more political will, and then you think that's the end of the discussion. No, there's a whole science about how to work and have you analyze who are the winners, who are the losers, who are the advocates, who are the decision makers. How can you make a difference? Because unless we work strategically to identify and empower the patients, the insurers, the groups that will win from blood pressure control, unless we counteract some of the forces that are working against progress, whether it's food and beverage manufacturers or specialists or hospitals, unless we change the structure of how healthcare is paid for, we'll continue to lose, but more importantly, still millions of patients and their families will be losing. But progress is possible and victory is possible. Thank you very much.
Thanks. Thank you, Tom. So much food for thought. Yeah, I'll move that in a minute. Thank you. So much food for thought. We really do appreciate you coming to share your expertise. But now I want to pass to our panel, also experts in this area. May I welcome to the stage Dr. Bente Mikkelsen, who is the Director of Non-Communicable Diseases from the WHO. Well, if you'd like to come and sit next to me, that would be great. Thank you. Also, we have Dr. Lillian Mbao, who is come from Kenya. She's the Chief Executive Officer of the Kenya Cardiac Society, medical doctor by background, public health. Works with the government there in Kenya to develop policies and NCD programs. We also are delighted to have Dr. Anek Kanok-Silp, who is the Director of Chest Disease Institute at the Department of Medical Services in the Ministry of Public Health for Thailand. So thank you for coming. And also from Australia, Joanna Munro, who's the Director of Prevention Systems for Health and Wellbeing, which is an agency in Queensland, Australia, based within the provincial Queensland government. Also a clinician by background. And Sandy Summer, who is the Corporate Senior Vice President, Head of the Therapeutic Area for Cardio, Renal and Metabolic at Boehringer Ingelheim. So thanks very much indeed for joining me on this very hot day. Bente, I just wanted to ask you to reflect, given your experience with the WHO, on what Dr. Frieden has said. There's an awful lot you could pick up on there, but what do you think were the salient points that he mentioned, and thinking about how we can move this forward?
First of all, I think you would be quite disappointed from the onset because, you know, Tom Frieden, Resolve to Save Life, and WHO are working so closely together. So he's a much better speaker than me, but you would normally hear me saying exactly the same thing. So I think we know very well what the situation is. So we have the data. It can always be improved. But we have the data, we have the silent killer report, which is really a shocking piece of news with fantastic opportunities. So there is no lack of evidence, there is no lack of what to do, and it's no lack of also the return of investment, if you want. So the big question is exactly what you asked him, you know, and so what? Why doesn't it happen? And I think we need to really understand this a little bit deeper. First and foremost, we live in an era of perma-crisis. So it's probably never been more difficult. If you just look at the World Health Assembly going on now, the main topic is preparedness. And it's understandable that it is preparedness. It's also because the competition of public and development aid is so strong. So you hear the discussion is really about the investment round for WHO to just secure WHO as the main health agency. And this is also happening on the national side. So the sort of the experience priorities is very, very difficult from many politicians. But that said, I think if I start at the global level, we have a golden opportunity to change this for real. And that opportunity is the next 4th high-level meeting on NCD. But it requires from us to be much more simple and precise and focused. We cannot talk about everything at the same time. We need to really help the politicians. And we have this best case. You know, as Dr. Frieden said, you know, 1.3 billion, only 50% of them know they have hypertension. Only 1 in 5 is actually on management. And this is where we have a situation where we can only need the manometer or maybe the iPhone. We have the cheapest medicines. And we don't even need a doctor, if we should be real. So, you know, what I wish for the 4th high-level meeting is that we dare to maybe use hypertension as the only focus and only example, and do like Sierra countries in WHO has done, saying that they want to put 100 million people on treatment for hypertension and diabetes before 2025. I think we could do the same globally. Yeah. It's not because that is the only thing to do, but the sort of, let's call it the salmon effect. You know, if you do this well, like they do in Philippines with Phil Heart, then suddenly a lot of things follow.
Yeah, I was taken by what Dr. Frieden said. He said we need to speak more effectively. He said he would come back to that, and we didn't expound too much on it. But you're talking about speaking more effectively, concentrating on a single issue, talking to the politicians in a different way to make them understand. So, you know, with that in mind, so when you're going to the UN high-level meeting, what will you be asking them for?
So they will ask us, by the way. So it's not we asking them. Well, okay. But I think, you know, what we are the technical agency, so we can support them in creating a paragraph in the political declaration, setting a goal on hypertension treatment as the sort of the lead indicator when you want to talk about NCDs in general. But it's also other opportunities, and we have been very strongly arguing and also explaining, you know, how the situation is in Gaza, in Ukraine, in all the humanitarian setting when people don't have their treatment. And I think we just need to understand that if you don't include NCD and hypertension, cardiovascular into the preparedness and the response, you have even more people dying. This is what we saw during COVID. And that's the most hard-hitting argument so far. That was a wake-up call, and I think it's important. I want to add one more thing. Okay. Because very often people talk about the diseases of the poor and the poverty, and they think about malaria, TB, and HIV, and so on. And of course that's true. But really, the main driver of poverty and also the poverty-induced diseases is NCD. And that is because we lack totally the financial protection. And this is a more simple way to say than, you know, we need to have essential benefit package, we need to go into UHC, it has to be funded. But if you look at, you know, the mother on the ground having hypertension and have to choose between the treatment, and that is even, I mean, the treatment should have been super, super cheap. But in her place, it will be very costly because of all the markups. She has to choose between that treatment and taking care of her children, maybe finding food. I think we need to use that kind of language. We need to add human rights to this. But in the end, it's a fantastic business case. Hypertension treatment and diagnosis is the best business case we have.
But briefly, I want to come on just to talk. You know, Jagat talked about a bold new vision. We talked about, you know, refreshing what's being done at the moment, and I want to address integrated care models. How are they helping? Where are they helping? How can we integrate care with all the different multiple abilities that we have?
Yes, so I think before we jump to that one, I think one very powerful tool we have is to showcase success. So I just listened to the Minister of Health of Philippines, and I've been there myself, so I know that Phil Hart is fantastic. And I could see that the other ministers, the other countries were really intrigued by his experience. So I think we are not using that power to the extent that we should. Integrated care, yes. I have to say that is the solution, but not as integration. I'm quite tired of listening to a lot of debates where people say, okay, what to do, this is so difficult, so many things to be done, and then somebody raised their hands and say, we have to integrate, and then everybody is happy. And I ask, well, fine, but how? Because I think we cannot stop measuring really the impact at the level of the patient. So it's only when the hypertension in this case is diagnosed and treated that integrated care actually has an effect. And I think we need to continue to understand that, because this integration, if you move to a country level, even in my very rich country, Norway, it is about the nurse or the family doctor that actually have to think about everything: diabetes, early cancer, vaccination, and hypertension. So if we are not able to really continue to talk about these different diseases in, of course, a person-centered way, and usually people have more than one, risk or disease, we need to continue to measure the impact. So yes, it's very important. It's the way forward. It's proven to be the best way to do decentralized, community-based care, integration, but we can never stop really looking for the real result. Don't try to cheat ourselves to think that this is possible just because we have a lot of tools to offer. Thank you.
Great. Well, thinking of best practice, I want to move to Kenya, and I'm delighted that we have Lillian, who can tell us a little bit more about how Kenya is progressing towards 3.4. Tell us a little bit about what's happening there.
Yeah, thank you so much, and thanks to the organizers for inviting me. I think just to give you a bit of a context, we are not progressing well. We are not on track to meet our targets. But just some context, we are still having a double burden of diseases. So currently about 41% of deaths are due to NCDs, and the rest we are still having to deal with the communicable diseases. And but it's estimated by 2030 NCDs will have overtaken. So we will be now dealing with a much higher percentage of NCDs, so it's good to remember that. But we are also dealing with a health system that is not adequately financing the healthcare. So we are currently at around 8% of domestic financing. Rather, the government expenditure on health is about only 8% as opposed to 15%. And when you look at the probability of dying prematurely from NCDs, it has gone up from 18 to 21%, according to the WHO data. But we have some progress I can report on. For example, because as a country we are focusing a lot on UHC, universal health coverage, for us that has given us an opportunity to look at the burden of disease holistically. So now our government has had to really focus on both communicable and non-communicable as we are doing the benefit package. And that has been very consultative with both the NCD and the communicable disease community. So I think that was a good thing for us. And there's a lot of focus on primary health care, which is also good. In terms of the best buys, we are doing quite well in terms of tobacco control. For example, you rarely find public smoking in Kenya, for those who've been there. Packaging, warning labels, there is no advertising. So at least tobacco control, I think we are somewhere. In terms of vaccinating girls against HPV, that's also there. We have a national multi-sectoral strategy to address NCDs. We have evidence-based guidelines for management of most of the major NCDs. We have decentralized care for NCDs, including hypertension, diabetes. So at least as a country, we have focused on making sure that the primary healthcare facilities can diagnose and manage hypertension and diabetes.
But let me just press you, Lily, a minute. I mean, it's sad to hear about those, the deaths potentially overtaking. Those percentages you gave are quite shocking. What are the barriers? Despite all those great efforts that you're making, what's not pushing through to reverse that and go in a positive direction?
Yes, so what we haven't focused on is things like access to healthy foods. So, for example, we are still lagging behind in terms of food labeling, in terms of salt, restriction or regulation around salt, elimination of trans fats. Those are areas we are still lagging behind. Physical activity, we still don't have initiatives at the public health level to increase physical activity levels. Access to drugs. So as I said, we have, as a country, ensured that care for diabetes and hypertension can be available at the primary healthcare level, but we still have supply chain challenges. So at times, patients will go there, get diagnosed, but not find the medication. I think that's a big challenge. And one of the reasons is because we have a devolved system. So we have 47 governments. So you find a lot of variation across different counties depending on the priorities. So that's one of the things that has really, but of course working closely with the government to address that.
Okay. Well, look, I'll ask you more in our discussion later on, but thank you for that. That's really, really helpful. I want to move to Anek now. Anek, in Thailand, I think you've a good example of expanding universal health coverage and primary care, strengthening primary care. How did you do it?
Thank you, Chef. This is a great honor for me, personally as a heart specialist and as a representative of Ministry of Public Health of Thailand. Yes, in Thailand, we achieved universal health coverage 20 years ago, and since 2002. And USC eliminated the financial barrier and ensure that every people can access healthcare services, including NCD intervention, such as screening, early diagnosis, treatment, and CVD treatment like high blood pressure, hyperlipidemia, diabetes, CKD, and its complication, are fully funded by universal coverage scheme and almost zero co-payment. We have extensive coverage of primary care in all about 800 districts in Thailand. It is the foundation for implementing universal health coverage with equity outcome due to close client services and equitable access. And provision CVD intervention was fully integrated with primary health care. Yeah. Despite of this fully funded service, the effective coverage of diabetes is just really 11.7%. And for the hypertension, it's about 15.7%. Yeah.
So you're saying that you've had some tangible benefits and outcomes as a result of that universal health coverage.
Yes.
Yes. So
okay.
tell us a little bit more about the difference it's made.
Okay. Yes. In Thailand, we have introduced the stroke and STEMI fast track as service, all of which was fully covered by universal coverage scheme. And the outcome of STEMI is for 30-day mortality was reducing from 22% since 2002, and 20 years later is reduced to about 17%. Yeah.
So how did you get the politicians to agree back then to introduce and fund this coverage? I mean, if we could all learn from that, that would be fantastic.
We have maybe mostly from the tax and the funding by the government.
Yeah. Well done, and it's great to hear that you've had it. But just let me ask you, so is Thailand one of the countries that is on target to reach SDG 3.4, or maybe it's one of the countries that is not?
I think maybe it's quite difficult because of, even though we can have a UHC coverage for Thai people, but the adherence to intervention is very low. So that maybe afraid maybe we cannot reach. But the challenges for us is we should have the strong law enforcement, and transparent regulators and self-governance.
Okay, well, thank you very much, and we'll delve more into that later in our panel discussion. Now, I'm keen to, if you could hand over the microphone to Joanna. Joanna is very kindly here before she jumps on a plane back to Australia. So if she leaves straight after her speaking, it's not because I've upset her, it's because she has to dash. But your organisation in Queensland, that's actually quite an unusual having its agency within the provincial government. Do you want to explain why you were set up, how it came about, and what it does?
Absolutely, thank you, Jackie. Just for a bit of context, Queensland has a population of about 5.5 million. It's almost 7 times the size of Japan, about 5 times the size of Japan, 7 times the size of Great Britain, and 2.5 times the size of Texas. So back in 2019, the Queensland government established Health and Wellbeing Queensland as a dedicated prevention agency with a legislated remit to reduce the burden of chronic disease and health inequity. So we're coming up to our 5th year, and so it's been a busy time, and that was in response really to our Queensland Clinical Senate, so a group of high level clinicians who really wanted to take pressure off the health system. We have been set up with that remit, which is fabulous, and quite a broad remit. So we do have a Generation Queensland vision, so really aiming for children born today to experience better health outcomes than the generation of Queenslanders before them, and we're doing that through a number of key strategic priorities. So obesity prevention being one, food insecurity. So we have high rates of food insecurity, particularly in our First Nations community. So Queensland has a largely decentralised population with more than half living outside of the greater metropolitan area of Brisbane. So we've got high populations in rural, regional and remote areas. So food security is a big focus. Equity as well. We're developing an equity framework, particularly supporting policymakers with resources to have an equity lens. I'm working strongly with the health system to embed prevention across all layers of the health system, so primary through to tertiary as well. And we are now moving into the mental health and wellbeing strategy space as well. So some key strategic priorities. And we have 2 10-year strategies and 3-year action plans endorsed by the Queensland Government in the last 6 months, which has been fabulous, and really whole of system cross-government strategies and action plans. So,
And so, obviously this event is talking about cardiovascular disease and about why the SDG 3.4 is not being reached universally. Can you explain why you think CVD receives less attention than others? And obviously you're focusing on it, but are there any particular CVD programmes within what Queensland's doing?
I can talk from a prevention lens. Prevention investment is always low. A small percentage of the health budget in Australia, I think it's around less than 2% and has been for about 10 years. So we're always advocating for more more budget of the health budget to be spent on prevention. Ideally, we're looking at 5%. So as an agency, we are looking primarily at primordial through to tertiary prevention, less so on that treatment aspect, but obviously that has the impacts in the longer term and obviously makes good economic sense from a health system perspective as well. But we are looking at innovative models of care and piloting, projects that we can scale and spread across the state. So,
And what do you think other parts of Australia and broader in the world can learn from what you're doing?
I think what's key to us as a government agency is partnering. We're a small agency, but we have to partner, and we have to partner with industry, NGOs, academia. We've got great university partnerships, particularly for research. All levels of government, so not just state and federal, but also local government. So we work really closely with our local councils. So I think partnership is key, and particularly partnering with community, so community partnering. So we do have a community partnering strategy, a register of community voices to really inform everything that we do, so that it's relevant, accessible, and impactful.
Okay,
Yeah.
Thank you. Well, I hope that's okay for you.
Yep.
And please, you've got 5 minutes, so if you'd like to hear Sandy, you may. And I know that, yeah,
You have to
Sandy,
go, I understand.
let me come on to you. I mean, I would talk to Bente about integrated care models. How does Boehringer Ingelheim see these, particularly in addressing cardiovascular diseases and comorbidities, to contribute to getting to this target of...
Yeah, thanks, Jackie, and thanks for having us as well. We see it as hugely important, and let me just answer the question as to why. The why behind it is because the heart, the pancreas, the kidneys, and now the liver, as I was talking to Dr. Pinheiro about before, are intimately connected. And these interconnected systems, we believe at Boehringer, and I'm sure many of my colleagues agree as well, should be treated holistically instead of the way they're treated today, unfortunately, in many cases, in silos. And you may be interested to know, and many of you probably do know, that if you're a type 2 diabetic, that 1 in 3 type 2 diabetics also have cardiovascular disease. 1 in 3. If you have chronic kidney disease, 2 in 3 chronic kidney disease patients also have cardiovascular disease. So imagine if you're a patient, you're going in to see your healthcare practitioner, whoever that may be, and you're treated for your type 2 diabetes, but perhaps you weren't being screened for your cardiovascular disease or even your chronic kidney disease. And then years go by and you come back and your HbA1c control is fantastic, but perhaps you hadn't been diagnosed earlier for cardiovascular disease or for chronic kidney disease, or even perhaps something with your liver. You might have MASH. So we at Boehringer advocate for the holistic treatment of patients and an integrated approach to the management of cardiovascular, renal, and metabolic diseases. And we think with this holistic approach, and in fact we know through data, patients will live longer. We will help eat into the goal we have of reducing premature mortality by 1/3 by 2030. And we're very proud of the work we do in conjunction with many of you in the room and some of the partners up here on the podium.
Well, also we heard from Joanna about the importance of partnerships. I mean, maybe can you actually give us some examples of the collaboration between the private sector and cardiovascular health systems? I mean, I can see you want to support this integration with all the organs all interrelating, but how do you practically do that with multiple health systems?
Yeah, it's a very important question, and I'll start first with what we do as an organization. The core foundation to our business is making medicine. So what we're doing at a basic research level is trying to design medications that are targeted at pathologies that address multiple pathways. So medicines that address the cardiovascular, renal, and metabolic pathways, which is really where much of the science is going. So we're really trying to follow the science. But with respect to partnerships, I'd love to point out one example that we're incredibly proud of, and it's called the Angels Initiative. And effectively, the initiative is to provide protocols in hospitals, and as many hospitals as that we can get to around the world, whereby we put in place, in partnership with the healthcare professionals at a local level, systems and protocols and pathways that help manage the patient better when they have a stroke. And the key to stroke, as we know, is time. And patients who can be managed quickly and as fast as possible obviously lead to better outcomes and help reduce mortality. So we have implemented at over 6,000 hospitals around the world this Angels Initiative, including many underserved areas as well, where we are going in, and it's in partnership, by the way, with the World Stroke Organization, the European Stroke Organization, and the Stroke Alliance in Europe. So it's a collaborative approach where we are all working together, rowing in one direction to try to make sure that patients who are suffering from stroke have the best possible outcomes, and including underserved areas. And interesting, we're also moving into Africa as well very shortly to ensure that everybody who deserves the best care can have the best care.
Sounds great. Thank you very much, Dee, for elaborating on that, Sandy. Thank you very much indeed, Joanna. It's very, very, very good to have your input into the panel discussion, so thank you. Let me just come to our wider group. We have a discussion now before I'll open up to questions in about 15 minutes, but if we see this as a problem and then solutions, I'm just wondering whether or not there are any barriers that we haven't yet discussed that the group thinks are important that need to be tackled. Lillian, is there anything that you wanted to mention and add that, you talked about the tobacco and food labelling, etc. What are the other barriers that we haven't mentioned?
I'll probably mention two. The first one is, and I talked about it earlier, for our countries, we still have to increase domestic financing to health. I think that we will not make a lot of progress if our health systems are underfunded. So for me, that's critical, and that's what we are trying to push. And I think we need to work with all the other health actors, not just communicable, just everybody to really push our governments to finance health.
But I guess everyone's fighting for their own share of the...
Exactly.
Yeah, I
That's
mean,
the thing.
You've got some very good arguments. If you say that deaths are going to be overtaking communicable diseases, you've got some,
Yes.
evidence there to say actually you need to give us a bigger share. But
Yeah.
it's a noisy environment, isn't it?
Yeah. And then secondly, I don't know how now we can have more pressure from the top level. So we are doing our part from the down level, but if we need to see how we can have more accountability for countries so that they can implement the policies. So how can we work together as a global community to put pressure on governments to implement the best buys and to finance health better? So I think we need to work bottom up and also top.
Yes, okay, thank you. Bente, you wanted to come in.
Mm-hmm. No, so I think it's still space for strengthened political commitment, especially at national level, and also empowering the national level to take the charge. It's not only about accountability, it's also about stewardship. So I totally agree on that. And I totally agree on the financing side, and that's also why we have the international second dialogue on financing for NCD and mental health now in Washington, D.C., together with the World Bank, 20th and 21st of June. This has been spotted as the main problem for the NCD agenda. I think we haven't used, all the tools that we have. I don't think we have mobilized and supported the people living with all the consequences of hypertension, in this case, people with stroke, people with kidney diseases, also the link to diabetes. I think we need to support them more. We have started, but I think the voices of the people are the strongest when it comes to accountability in their own regions and countries. And I think we need to make the data available not only for politicians, but also for the practitioners. I can see a huge game changer when, even if it's a volunteer nurse, not trained as a nurse, if they have the data at hand and can see the change when they actually measure the blood pressure. So I think that is, but there is one thing that has only been mentioned in the bypass, and that is the access to medicines and technology. And this is one of the worst sort of moral facts, I think, in the whole sort of discussion around cardiovascular diseases. I don't remember exactly the markups, but many of these molecules that we should use, and was mentioned also by Tom, is very, very cheap. This is old molecules that exist and are effective. And when they reach the patients, there are so huge markups if they at all are available. So I think we need to get support from the World Bank and from other sort of financial institutions to make a sort of a global facility, a regional facility. There has to be a support for countries to actually come up with their forecasting. At the moment, nobody are doing that in a proper way because there are no money to actually support, so it's a very vicious circle. So we need to put pressure also on the private sector, but also find solutions, and we need to go back to the old innovations the old molecules which we have in our protocol-based guidelines. And I would like to say, I think we also need to speak to the cardiologists and the family doctors, because of course there are very tempting ideas, new ways of treating and so on, but let's do the basic first and then we can refine, you know, and I think that's also something that needs to be done, and I think to mobilize, and I'm looking at the World Heart Federation here, I think to mobilize also the experts in all countries to help. This is a little bit what we do now with tobacco, much more efficiently, and I think we can sort of agree on some very, very clear measures on this. So I think that's my my most important comments. I will add one thing, and this is also a sign of a positive development, which is resonating with what my colleague in Kenya is saying. We have for the first time now got proposals through the Global Fund. And the Global Fund is originally set up for the Millennium Development Diseases. So far, we have reached agreement on HIV and cervical cancer, and we need to do the next step. They need to also include, because at the moment they have a very bad business model. They support people with HIV, which then immediately are dying from cancer and cardiovascular disease. That's a really bad business model. They understand that, and we need to help them, and that has to come bottom up. So let's continue with the comorbidities.
Yeah, well, I will. There are lots of comments there I want to bring up, but I do want to give Sandy the opportunity to respond to some of Bente's comments. And I don't want you to be, a spokesperson for the whole of the pharmaceutical industry, but obviously her comment about, the older molecules that just those alone.
I was going to touch not even on the older molecules, but I completely agree. The medicines are so readily available, and for so many molecules that are cheap, and patients need, and deserve to be on them when appropriate. But getting back to the why behind why haven't we been more successful? One of the things that I've witnessed in the United States has been a lack of good execution and implementation. There's lots and lots of very good ideas floating around, but there are very few groups, even in places that are well-resourced, that can actually implement well. I'll give you an example of one that actually does implement well. It's called the Cardiometabolic Health Alliance, and you can actually look it up online. Cardiometabolic.org, I believe, is the site. And they take an interdisciplinary, multi-morbidity approach to treating patients. And what they've published is now data showing that patients actually live longer, and as importantly, they've reduced costs to the healthcare system. So again, building on the comments earlier, if we can demonstrate these wins and this success at a local level, it kind of catches wind a little bit, and more people will follow if you can help patients and reduce costs. And that's what this group has done. So we're trying to support organizations like that from industry to make sure that we're doing our part to partner and shape how patients are being treated.
Sure, thanks. Okay, Bente mentioned about communities having voices and that being very effective. Lillian, how's your organisation attempting to use the local population and the community to raise awareness of NCDs?
Yeah, so one of the things we do is working with patient-led organizations. So we do work closely with them in the area of advocacy, but also working closely with WHF during, World Health Days, like the World Hypertension Day, World Heart Day. We use those opportunities to do press briefings, put out newspaper articles, screen people for hypertension. So that's one of the ways we are trying also to get communities involved and aware of hypertension and cardiovascular diseases.
Yeah, and you mentioned we talked about integration, and you've talked about HIV, Bente. I mean, I was taken by someone mentioned to me about an integration of HIV clinics, a PEPFAR pilot, hypertensive care into HIV clinics. I think that sounds like a really positive thing to do. So as you say, you don't want somebody having long-term HIV being managed, but then their hypertension is what kills them. Yeah. Any other innovations that we can talk about that like that? Yes, Anek.
Yeah. And one issue that I want to mention is about even though in Thailand the prevalence of smoking, tobacco use is reduced, but nowadays they have new ENDS, electronic nicotine delivery system. The target is the kid and the children, because of in Thailand they have generation 5. It looks like a toy, and can family parent cannot detect they use this device. So that I think in the future it can be a problem. Yeah.
Absolutely. You know, vapes and electronic cigarettes, huge issue. I'm presuming also, yes, with you in
I
Kenya.
think I totally agree. I think there is a lot of work going to make sure our youth are getting into the e-cigarette movement.
Yeah. And what about accountability, Lillian? I think that you've talked in the past about how we need to have better accountability mechanisms. Kenya, you're doing your best, but how can you be helped to make governments accountable for the benefit of the health of their communities?
I think it applies to everybody. They make commitments at this, high level, but then when it comes down to the country level, we don't see much effort as much as we as civil society are trying to put pressure. So I think there was more accountability mechanisms for HIV, I think, globally. So I think similarly we need to see that same kind of accountability coming for the NCDs. Yeah.
I think, Bente, you want to add a point?
No. This is exactly why I'm actually asking all of you. You are the stakeholders. You know, we have an opportunity to get political declaration that is more tangible. And it's clear that, for example, for cervical cancer, just having the 90% vaccinated, 70% screened, and 90% on treatment is extremely effectful. And it also speaks to people at the level of communities and clinics. They have something to be proud of. So we need to have a similar thing for hypertension and cardiovascular. So I'm very happy that Dr. Tedros, it seems like we will have, only very few indicators for NCD for the general program of work, and one of them will be on hypertension, and one of them will be on diabetes, one on cervical cancer, and one on eye care. And people have asked me, why are you then not sort of focusing on oral health, chronic respiratory, you have it all? And my answer is, no, I wanted to put something forward that is possible and is also is resonating with the epidemiology. Because that has to be taken into account, and that is something we all need to stress. As you were I was so happy listening to you, because, having people from the ministry really, and they see it, the epidemiological shift, while for example, financing institutions are still pretending that the biggest problems is elsewhere. So that's why we have this inverse relation. Only 2% international funding for NCD still, and so we haven't really funded the SDG yet. So I think focusing on the reality, on the epi shift that we have seen, and giving that a voice, also being super focused on doing something we know can be done and show the case, that would be my strongest wish. And I hope we could, work together to put pressure on your heads of states when they go to New York, and of course before, when they negotiate the political declaration.
Thanks very much, Bente. I'm going to open up questions to the audience, so please do put your hand up and say who you are and ask a question. We've got some roving mics in the room. So instantly we've got a question from the back. Yes, sir, in the corner. Thank you.
Thank you very much, Jackie, and to all the speakers. I'm really intrigued by everything I've heard, because I think the whole agenda of really attaining the SDG 3.4 is something, in my mind, simple but not easy, right? The measures that are required are not that complicated. And just a comment to Dr. Tom Freedom. Actually, I don't think his was a failure, really. Because whenever a program is attempted but doesn't work, I take it as a lesson learned. And I think he also mentioned some of those lessons. We learned some lessons when trying to integrate healthcare at the pharmacy. So about 8 years ago, in 2016, after realizing that the pharmacy was the first contact for many people back home in Kenya, we decided to start telemedicine at the pharmacy. And we spent about 1 year in partnership with a pharmacy chain. And we realized our lesson there was that the insurance companies had to be on board for that to happen. And fortunately now, 8 years later, that is actually happening. So there's a big push by a number of insurance companies to bring telemedicine, and they're ready to reimburse it at the level of the pharmacy. So that's a big plus for us, and we're very happy about it. A second model of integration that we've carried out at Daktari Africa, which is the telehealth organization I run, is taking healthcare down to the rural hospitals. So one of the challenges that Lillian alluded to is a shortage of healthcare workers. So you'll find many small hospitals that don't actually have doctors. They have what are called clinical officers or paramedics. So very often patients will go there and they'll be managed, yes, but whenever they have NCDs, they need to be referred to a high-level institution that does have doctors and physicians. And that usually is a tall order for many people. And so what we did was use telemedicine to bring the physician down to those levels. And it worked very well. We published a paper with positive results, sponsored by Pfizer, by the way, to pilot the whole thing. And fortunately, we found positive results. Statistically significant improvement in blood pressure. We republished in the European Heart Journal. So I think there are several barriers to achieve universal health coverage. And one of those is actually the prevalence of hypertension, especially in young and younger people. We're finding very young people in Kenya right now, even ladies in their 20s. Young men are drinking a lot because of COVID. The lockdown had a huge impact. So, but again, using these basic integration models, using technology, I think we can go very far. So I'm very happy to hear yourself, Bente, talking about this, and I would like us to take this up as well.
Thank you.
And the gentleman, Sandeep from Boringa, I think it will be a great opportunity.
Okay.
Thank you.
Thank you. So I'll come to Bente and to Sandy. Using technology to, like telehealth, etc., to get access to universal health coverage, and also the impact of COVID may long-term be part of the reason why these goals are not being reached, the SDG. I don't know. What's your thoughts on that? And then I'll come to Sandy about the partnerships.
No, as I said, I think it was a big discovery for most countries that actually people at the biggest risk were the people suffering from chronic respiratory diseases, cardiovascular, diabetes during COVID. So this was the biggest wake-up call we have had in the NCD community, I think, since the onset of the agenda. So that helped us. And we also saw telemedicine solutions coming up, and it was sort of a grassroots thing. So we saw it big numbers in India. The problem I see is that there has not been a leadership, to continue the good progress that we have seen. So that's very often what happens, when things are normalized, we go back to the old way of doing it, and nobody really picks up the torch.
Where should the leadership come from, do you think?
I think it has to come from the immediate leadership. I really enjoy what we do in cities. I think that's fantastic. In regions, it's not necessary and it's not very efficient if it comes from global level. We can support, we can have the policies, we can have some decisions, but the real thing is really happening. And that's also why I want to mention one thing that hasn't been emphasized so far in the debate, and that is the focus on implementation research. So that's another sort of passion of mine, because as you said very clearly, and also Tom said, what has been tested, sometimes we test it too early, sometimes the context is not right, and then it changed, and then we never tend to go back, Just think about the kangaroo methodology to save premature children. I implemented that in the Norwegian healthcare system. It was totally forgotten. It was never happening in Norway. And it was so efficient, So sometimes I think innovation is also to really relook in what is possible. But I think to be going at scale for digital, we need to be also careful, because we can also have a digital divide, so it needs to be carefully done. But for sure, it's a potential. The whole area of of research and innovation and the need for implementation research to guide all of us. Learning from you in Kenya, I mean, it's beautiful, many of your examples, they need to be amplified, not only by feature stories. But again, we are up against something, and that is a huge lack of funding for these kind of things. People tend to fund, you know, what they think is on the forefront of sort of development, while I think the forefront of development is actually the complex but very good implementation that we all could learn from.
Sure, thank you. Sandy, I will come to you, but I want to, Lillian, did you want to, you're obviously from Kenya, did you want to comment anything Charles said, or?
No, I mean,
No.
I just agree with,
Yeah.
with him.
Okay,
I think we have had a number of technology-related research and pilot projects. I think I just want to agree the biggest problem is funding.
Yeah.
When it comes to scaling up, the question is always who will pay for it.
Yeah.
And we usually hope it will be government, but then back to funding issues.
Yeah.
So I think that's also another area which...
Okay, thank you, Lillian. Sandy, yeah,
I think the
Pfizer
technology
example,
question,
yeah.
thank you for raising it, is such a big opportunity to serve more patients, and I think COVID was you know, an accelerator for the almost ubiquitous wave of telehealth that happened after that period. But I'll give you another example as well. We really believe also screening and using technology for screening and understanding when patients are presenting with certain diseases, and I'll give you an example. So for chronic kidney disease, there's a very simple test, and it's not that expensive, but it's highly underutilized, and it's a UACR test. It's a dipstick test, a urine test, and it can tell you in combination with your EGFR test if a patient has chronic kidney disease, yet it's not being utilized. But today there's a company, actually, it's called Healthy.io. You take a dipstick, you can take it home, you can be anywhere in the world, you have an app on your phone, if you have a phone, you do have to have a phone, and you hold it over the result of the test, and it'll tell you if you need to go talk to your clinician about your kidneys, because you could be in, quote, the danger zone. So just building on what you said, it's another example of how we need to be thinking about leveraging technology to bring more care to patients at a local level.
Great example, thanks for that, Sandy. I've got two questions at the back. The gentleman has had his hand up first in the... That's right. And then, okay, lady here, then, yeah, thank you.
Thank you. My name is Moe Makoka. I'm working with the World Council of Churches, and I want to highlight we have a program, we're calling it Health Promoting Churches. The World Council of Churches is a family of over 350 churches globally. And this health promoting churches is building on a couple of concepts. You might remember the Ottawa Charter of Health Promotion 1984, which said health is not made or broken in the hospital, but in the settings where people are. And there was that healthy settings approach, which had health promoting schools and healthy cities and so forth. Unfortunately, places of worship were not recognized as a place that could actually be part of those healthy settings. So that's one motivation. So it is, if you like, a protest on our part, saying,
yes, okay.
Why didn't you include us?
Yes, okay.
But also the theme of religion and development. There's a lot of data about religion and development, and further, what are called religious health assets. So religious health assets are very critical. So we're building on these. And what can churches do?
Sure.
One, health education.
Let me stop you there, because we've got very little time left. Let me just come to Lillian. Lillian, using churches, using faith-based organisations to promote awareness of health, is that part of what you do with the Kenya Cardiac?
Yes, actually we have worked with the church organizations. There's one in Kenya called CHAC, Christian Health Association. So I do agree, and if in fact if you go to many of our churches in Kenya, you'll find they have a health committee, and they do regular health sort of education and sometimes screening. Maybe it's not happening in a more organized sort of way, but actually I do agree, and it is happening in a small way, and looking at ways to scale it up would be a good avenue.
Okay, thank you. Lady.
Yes, I'll try to be loud. So mine was also, don't forget about this comment as well.
Right, okay.
On emergency care. I
I blame us for not being at these forums. This is my first time, for example, at World Health Assembly, but I've been doing public health research on non-communicable diseases in Kenya also. Sorry, we're dominating the conversation today, but for like 10 years. And I know there are more and more of us that are addressing it, but right, DCP3 said that 50% preventable mortality is through emergency care interventions. Tobacco, alcohol, CVD is disproportionately higher, people present to the ED, and yet we're not anywhere on the NCD agenda. And I've put my comments in the open feedback or forum, but please don't forget primary, emergency care.
Yeah.
UHC is coming, but it's not there yet. Primary care is coming, it's not there yet. They're still going to the EDs for episodic care.
Okay. Yeah, good point. Thank you very much indeed for that. Okay, I've got 2 more questions here, Selina. It's coming your way via the conservatory.
Hi, Selena Gore, CEO at Women Heart. I'm really happy to hear implementation science. Bente knows well. I've been working on that space for a long time. I love the salmon analogy of hypertension being the way we're going to get there. My question to the panel is, what is the gender lens across all of these things that we're talking about? We know that if it affects women worse in terms of access issues, but also we know that when women are healthier, societies are much healthier. So just a question to see if anyone would pick that up.
Okay, Sandy, yeah.
This one work too? Yeah. So I think it's an excellent question, and I'll give you an example of a program that Beringer has a partnership with. It's called Hear Your Heart. And actually you can go online and read about it. It's called hearyourheart.com. So if we think about heart failure, and you probably know these statistics much better than I do, but despite men and women being treated for their heart failure, for some reason, men have better outcomes. So we've put in place an initiative particularly to address the inequities in healthcare for Black and Latina women, such that we want to make sure they are equipped with the information they need to have the conversations with their healthcare professionals about their disease, about their heart failure, so they can engage their practitioners and their clinicians to make sure that the clinician understands what's happening with them, so that they hopefully will have the same types of outcomes that their male counterparts are having.
Yeah, thanks for the question. And I think the NCD Alliance Lancet document did spell out the countries at that stage that were trying to get to the target by women and by men. And I'm interested that we haven't really discussed it so far. I don't know whether Anek or Lillian or Bente had any further comments to make on the gender divide with CVD and these goals. Lillian first.
Yeah, I mean, I can just say that we did once a large-scale hypertension screening project, and actually majority of those we screened were actually women. I mean, but we haven't looked at we haven't done a lot of work in the cardiovascular space. I mean, those who already have heart disease. But I think, yeah, it's something that we need to look at as a country.
Anek, do you treat women and men differently in terms of cardiovascular care?
In Thailand, we have not different because of actually I'm a cardiologist, so it's some issue that may be different from men and women, but in the majority is quite similar.
Yes. Okay. Yeah. And yeah, Bente, fine. Okay. Well, one last question from the lady. Thank you.
Hello, my name is Bronwyn Hennig. I'm director of the Global Health Policy Lab, a new initiative just started, really. I wanted to ask a bit more about impact measurement, much as I hate this word. But, you all refer to simple solutions. We have the data, we have the political will, and still these things are not rolled out, they're not shared either. So could you comment on either means of measurement, means of sharing, in order to facilitate building on lessons learned from others, and also reverse translation, especially from low-middle-income countries to high-income countries?
Wow, okay, there's a lot there. We've got 2 minutes. Who'd like to take that one on? Bente, is that something that you can talk about in terms of impact measurement?
Yeah, it's a huge topic. So I will try to be super short. So as I said, I think hypertension and coverage, we need to pick 1 or 2 measures and push for it. So that's at the global level. I mean, we need to find one way of doing this. So this is what I was saying. If we, I fully support to have integrated care, community-based primary health care and so on, but we must not lose in sight that in the end of the day, it's the management of hypertension that can be a very good impact measure. So I would like to say that we also develop facility-based indicators. We have a wealth of indicators. Everything in WHO is public, it's possible to use, and so on and so forth. Is this the last time I can speak? Because I want to say something else.
Go on then. Yeah, you got 30 seconds. Yeah.
This is the last, yeah. No, I just wanted to give a little bit of hope. For me, it's about global solidarity, but it's also about sustainability, and we need to use that as well. And I saw 2 examples that really made me both thoughtful and happy. One was in the spring meeting of the World Bank. And actually, the president of the World Bank mentioned in his short fire chat with Dr. Tedros hypertension and NCD. If you haven't heard it, please look at it and share it. I mean, it means a lot. That's a guy that is really one of the key for global solidarity and also for equity and for development, right? And then I have another one, and that was my former boss. That's Dr. Ren Mingui. He went back to China. I called him and I asked him, please don't forget about NCD and mental health. And his simple answer was, it's not possible, it's not a choice anymore. If China is going to sustain, we need to address this. I think for me that's sort of very strong messages that we can rely on and build on that. When you understand to act. When you understand to use your measures. So let's continue that.
Okay, thank you. Well, I am going to ask you to speak for one last time. I'm just that brings to the end of the close for the Q&A. But we've just in the last minute, I just want to ask each of our panel, just for a very, very short, 30 seconds or less, what's the one thing you want either your organisations or other organisations to do to try and progress this goal of achieving SDG 3.4? I'll give you a bit of time to think. Sandy, what's your one takeaway message for this audience?
My one thing, and this is my lesson in life that I try to live by, there's so many good ideas floating around, but I very rarely see good execution of those ideas. Strategy's great, it's interesting, it's fun, it could be PowerPoint slides, but it's really the people who care to make a difference. And so my one message is, for all of the partnerships and the groups we work with, is care to make a difference. And those that care to make a difference actually can do 2 things. They can drive better patient outcomes, patients can live longer, and oh, by the way, you can reduce the burden of cost on the healthcare system.
Thank you, Sandy. Anek, what do you want the audience to take away as your key message?
I think we need a multi-sectoral strategy to achieve the SDG 3.4, and collaboration between government, healthcare sector, and public health organizations, civil society, and the public society is an essential goal to and maybe the challenge that we can continue strengthen the healthcare system.
Yeah, cross-sector support, absolutely. Okay, thank you very much, Anek. Lillian.
Yeah, I think we still need to focus on prevention. For me, I think for our countries, we need to put most of our focus on prevention at the policy level, health system level, and individual level. That's what I think.
Okay, Benti, 20 seconds.
So I think it's 3 things. We need to amplify the voices of the people living with and at risk of these diseases, and also invite them to co-create solutions. They are more sustainable. I think it's important to choose some very, very succinct goals and targets that can help us. Like, for example, how many millions on treatment for hypertension. And please reflect this in the political declaration for NCD. I don't think we have many chances like that one, so please let us use it.
Excellent. Well, we'll all look forward to that in September. Very, very important day. Thank you very much indeed for your attention, for your questions. But I have to say a massive thank you to our keynote speaker, Dr. Frieden. Thank you to you and also to our panel. You've been great. It's been a great discussion. So I hope that you enjoy the rest of the World Health Assembly. But from the World Heart Federation, from me, Jackie Thornton, thank you very much.